So you have 2 votes for, 1 vote against, 1 not voting, and 15 people not here. So my sincere hope is that we rectify that at some point this afternoon. We are shrinking up here. So thank you, Ms. Brown, and we'll keep the roll open for additional votes.
Thank you, Dr. Wood. I appreciate it.
Ms. Eggman. So this is item number 22. AB 2743, Ms. Eggman.
Thank you. It's my pleasure to present before this robust body.
August or robust?
So today I'm presenting AB 2743, and I first want to start off by accepting the committee's amendments, thank the committee for all their work, and especially thank the chair for his willingness to engage in this. So I think we all agree that while we need to invest a lot of money in our infrastructure like roads and water, we also need to invest in the infrastructure that deals with mental health. We know that 16% of people living in California suffer from some kind of mental health issue, and less than 60% of those receive any treatment. And as a mental health provider, I can tell you that one of the biggest indicators for somebody to be able to turn around their episode is the more quickly they can get services, the better chances they are of a better recovery. So what we're talking about here is developing a registry, a real-time registry, where there are open psychiatric beds. And I know there's some opposition to this, but and this will not in total solve the problem. But we can't just keep waiting for the magic bullets while we don't take the things that are available to us already within our grasp. So this will create a pilot program only involving the 9 Bay Area counties and adding in my county, San Joaquin County, pilot program that will sunset in 2022. And because of evidence in other states, this cannot be a voluntary program. It will be a mandatory program. So, like I said, a bed registry is only one tool that will help. It will give psychiatrists and other mental health professionals a tool to help patients when they are in crisis and need emergency care. When patients are in incredibly vulnerable or fragile states, their condition may be deteriorating rapidly, and particularly if they are in danger of harming themselves or somebody else, it's really important that they get into a bed as quickly as possible to start treatment. Currently, when someone needs a bed, the healthcare provider will start calling around. And I've worked as a LCSW in a couple hospital emergency rooms, and I can tell you when crises come in, and if you don't have a bed in your facility, you try to find another one. It's just a panacea of trying to call and see where there's a bed, see where there's an open bed, who do you call, you can't get through. So this will create a registry where every day in real time it is updated who has a bed, what is that bed for medically fragile, is that bed a locked unit, what are the parameters around that bed. So when somebody is coming in with an emergency, you need to place them quickly, you have way more knowledge and awareness of where that bed is open. You still have to make those calls and say, all right, we have a patient, can you accept them? But it cuts down tremendously on the time if you already have the data in front of you that says where are there beds open and available. The one state that has tried it did it in Virginia, but they did not. They did it more of a voluntary program. And again, if it's voluntary, it's not going to be as robust as it will be if it's mandatory. That created more problems than it fixed. So that's why we're, rather than starting this as statewide rollout, to try it as a pilot first with counties. The Bay Area counties have already started a very integrated network, so they seem like the appropriate ones to start it off with. Again, we don't say this will fix everything. I am committed to working on mental health during my time here. This is one more step, provides one more tool dealing with people when they are at their most fragile, sitting in emergency rooms. With me today, I have Randall Hagar from the Psychiatric Association, somebody from the Steinberg Institute, and Dr. Moline from as an emergency room physician.
Okay, so we have 2 witnesses, and please go ahead.
Lynn, I'm from the California chapter of American College of Emergency Physicians, speaking in support of this. An electronic data registry for inpatient psychiatric hospitals just makes a lot of sense. Right now, what we have is an antiquated inefficient system that is long overdue for change. What currently happens is when a patient comes in and needs an acute psychiatric hospital bed for emergent stabilization, a nurse, a doctor, or a social worker has to make repeated calls, faxing endlessly to different hospitals over and over again in the hopes of finding a bed. And this is not something that happens once a week. It happens every day. When I left my shift yesterday, we had 14 patients who were in the ER just waiting to find a spot in an inpatient psychiatric hospital. That means 14 patients where we need a nurse or a social worker to call each hospital individually over and over again for each of those 14 patients. You essentially have an army of clinicians not providing care, but tied to phones and fax machines, just trying to find a bed. Certainly in California in 2016, we can do better than this, than using phones and fax machines, which is old technology. The concept of an online registry is not new. This is not a novel concept. We have a system in place, the ReadyNet system, which is sort of analogous, where all the ERs and acute care hospitals update their status continuously throughout the state. So you can walk into any ER and see the status of any acute care hospital throughout the state, and it works very well, and it's very efficient, and it's been in place for 30 years. Certainly, we can do better than this for our patients with mental illness. We need to free our clinicians from the phones and fax machines so that they can start providing care and we can get our patients where they need to go. Thank you.
Mr. Chairman, if I could beg your indulgence, I think the Steinberg Institute and I would like to share the last 3 minutes, usually accorded to the second witness, if that's
I'll
okay.
allow that. Thank you.
Thank you. I am Randall Hager for the California Psychiatric Association. Just really briefly, I'd like to thank you and your staff for working with us to help refine and actually, to refocus us a little bit so that we can be more effective down the road. I would note that we have to be able to do better in this day and age than turning to phone books, turning to paper lists when we have electronic health records, when we have Facebook, we have Twitter, we have all these marvels of electronic communication. It seems to me that we need to apply those technologies to us finding the beds for our patients. So I would say that if we look very closely at what other states do, they do provide us some guidance. However, I would like to caution the committee about the information that's provided in the analysis from Virginia. Virginia has a very, very different treatment system. They have very different treatment laws. Instead, I would like to look at Massachusetts. The department chair at Massachusetts General Hospital has said that they know at any time in that state exactly where the hospital beds are. And I think that that is something that California could emulate. So I recommend this bill to you, and I'll yield to Anna.
Thank you.
Thank you. My name is Anna Hasselblad with the Steinberg Institute. We are confident that AB 2743 will improve the way we provide mental health care in California, especially for those in a mental health crisis. AB 2743 would streamline the identification of available and appropriate inpatient hospital beds for individuals in a psychiatric crisis through a secure and easy-to-use information sharing platform. The inability to know comprehensively what beds are available at any given time has resulted in patients languishing and further deteriorating in a setting that we know is not appropriate to their needs. AB 2743 is the start of a solution to a problem widely reported by emergency room doctors and staff, individuals and families, and mental health professionals across the state. We appreciate the committee's amendments and work with the author's office and co-sponsors, and are confident that a pilot project will demonstrate the efficacy of a registry and guide our efforts moving forward. This is a smart first step in connecting patients to appropriate treatment faster, as well as an understanding of the scope of the current access problem through data collection that will better inform how we increase much-needed capacity in crisis care services in California. Thank you.
Thank you very much. Others in support, just your name and organization, please. Okay. Witnesses in opposition. Oh, I'm sorry. I'm sorry. I don't mean to. Don't run, please.
Just Asha Harris on behalf of the California State Sheriff's Association in support. Thank you.
Thank you. Anyone else? I don't want anybody running and tripping. It's the health committee after all. Okay, anybody in opposition? Please come forward. So we had 3 witnesses, a total of 6 minutes. So if you choose to present that way, you can do that, but total of 6 minutes, okay?
Thank you, Mr. Chair and members. Alex Hawthorne here on behalf of the California Hospital Association. We are opposed to the bill. We became aware of the amendments earlier today and haven't really had an opportunity to look. We will review those and continue to work with the author, but at this time we remain opposed. I'm going to be deferring the majority of my time to 2 expert witnesses who have traveled to be here. One point of clarification I wanted to make: the Virginia Registry is not a voluntary program; it is a mandatory program. Okay. And an audit earlier in the year found that it has actually increased the amount of time for providers to find a bed. So with that, I am going to defer my time just very quickly by way of introduction. Dr. Paul Rains, who is president of Dignity Health St. Joseph's Behavioral Center in Stockton, and Dr. David Walsh, who is a faculty researcher in the Department of Psychiatry and Human Behavior at the University of California, Irvine. I think we'll start with Paul Rains.
Thank you. My name is Paul Rains, president of St. Joseph's Behavioral Health Center in Stockton. Thank you. It's rare that we're on opposite sides of this, and I really appreciate Assemblymember Eggman's support. Has been really the only person that's ever come and actually visited our hospital, and certainly understands the idiosyncrasies of what we deal with. One of the things that I really want to stress is that even though this conceptually is a great idea, okay, if there were actually enough beds, okay, something like this may work. I think I'm uniquely qualified in that our hospital operates a mobile evaluation service. We have our hands in every piece of this process, and we know all too well what the bed availability issue is. We work with the local EDs. We service 7 different emergency departments, and at any given time, one of the largest factors here is that the unpredictability of the availability of a psychiatric bed is way more complex than can be imagined. At any given time, okay, we are dealing with multiple factors. Just this morning, I came into work. We have an operations meeting at 9 o'clock every morning. We were full. We were at 35 capacity this morning. We had 4 patients in the local EDs waiting for a bed, and we had 7 referrals from surrounding counties. Okay, the minute we get those discharges, we fill those beds immediately. And the unpredictability factor is that we don't know where these patients are coming from. We don't know when these patients are going to be referred to us. We have to act upon this in a very real time. So bed availability is something that changes for us hour by hour by hour. We are constantly in contact with other hospitals, with EDs, constantly, finding out whether or not they have patients to refer to us. So it's not a matter that we're either hiding beds or cherry picking patients. I wish. It's not got anything to do with that. I would actually invite anybody who questions the transparency of what we're doing to come down to our hospital on any given Monday morning, or send one of your staff to come and witness what we do. And I can tell you that working and networking with other providers in the Northern California area, it's a well-known fact that any given weekend you will not find a psychiatric bed in Northern California. Not because anybody's hiding them, because they just don't exist. Because they are taken, and there is a waiting list. There are patients that do back up in these emergency rooms, and we clearly empathize with the provider community on the acute care side about this problem, and would love to find a way to do this. But I really don't think this is the way to do it.
Okay, thank you.
Nice to speak with you today. In addition to being a researcher, I work at the St. Joseph's Emergency Room in Orange, which is the busiest psychiatric emergency department in Orange County, at least. The issue of wait beds for psychiatric treatment has been well studied by the American Psychiatric Association and the emergency physicians. The factors that contribute to it from the emergency department end are overloaded emergency departments to begin with, and then you have a medical triage process that might triage these individuals from lower to higher levels of care, and then you have a wait time associated for a specialist to arrive, either a psychiatrist or a psychologist. There's shortages of both right now at present in California. And then you have gatekeepers to contend with for insurance reasons. And then you have patients who exercise their own preferences about their own insurance. And then once you get those things accomplished, you have availability of ambulances. once you get to an once you get to an inpatient bed, the main issue that is affecting things at that level is length of stay. And what I mean by that is the average length of stay is 8 to 9 days, depending on what study you look at. The reason it is that way is because the psychiatric medicines used to treat these conditions take anywhere from 5 to 14 days to exert their effect. So what we're left with is people arriving faster than we can resolve their problem, and that's the reason for the backup. So as a researcher, I ask myself, how will a bed registry remedy these problems? And unfortunately, there's no association between a bed registry and the factors that are committing or contributing to this problem. And those are the issues I'd like you to consider when you're entertaining your vote.
Great. Thank you very much. Others in opposition, just your name and organization, please.
Nisette Short on behalf of Adventist Health and Loma Linda University Health, in opposition for the reasons stated.
Thank you.
Greg Herner on behalf of Alameda Health System, which operates John George Psychiatric Hospital.
Thank you.
Jonathan Clay on behalf of Scripps Health, also in opposition.
Great. Thank you. Anyone else? Anybody in between? Okay, seeing none, we'll bring it back to the committee. Questions or comments from the committee?
Sure. So this has become a pilot, Ms. Eggman, with the amendments. Why isn't it good enough for the state? If it's a regional issue and it's that important, shouldn't it be statewide?
Well, that was the initial bill, Mr. Ridley Thomas. Okay. The initial bill was to do it statewide. And as you can see from the private hospitals, you don't see the public hospitals up here objecting. From the private hospitals, there is some resistance because change is hard. And so we thought a better way, and with the guidance of the committee staff and the chair, to try to do it in a place that is already renowned for their integrated service as it is.
Oh, you mean the Bay Area?
The Bay Area.
So so your amendments remove the opposition of public hospitals?
The public hospitals have never been. It's the private hospitals.
Maybe I misread. So, is the Seneca Healthcare District a public or a private entity? Is Pioneers Memorial Healthcare a public or a private entity? Is Oak Valley Health Hospital District a public or a private entity?
My understanding, Mr. Ridley Thomas, those are non-designated public hospitals.
Yeah. None of the county hospitals or the 23 public hospitals are opposed. Like in my county, in addition to St. Joseph's, we also have a county hospital. They are not in opposition.
Okay, so the hospitals here, Mr. Chairman, you're saying are non-designated?
Correct.
Okay. So from the opposition perspective, I don't see any opposition. What's the issue with non-designated private hospitals and their opposition? Do you know?
Yeah, thank you for the question, Assembly Member. I know we received over 70 individual letters of opposition from our hospitals. I will have to follow up with your staff to get you the breakdown of that particular question. I'll make sure to follow up with you.
Okay, thank you. So if a registry system, it seems odd for it to be in one region, does it not? Ms. Eggman, because when I was thinking pilot, I was thinking that it would be voluntary for those who maybe wanted to invest in or thought that this was a way forward, but maybe it wasn't an imposition on institutions or health systems that did not agree with it, and that it would be time set. I think that your amendments are time
2022.
Yeah, so that's what I'm thinking of in terms of a pilot as opposed to one region versus another. I don't know how many health for the purposes of healthcare, how many regions there are. Generally, I think of the state as 8 or 9 regions, essentially metropolitan statistical areas. Do you have any response to that query?
The query remains the same about why we're not going statewide.
Okay.
Is that your query?
Yeah.
The initial bill was to go statewide.
Right.
In working with the committee, it was determined to be able to prove that, to demonstrate if it's going to work or it's not going to work, and to be able to iron out any kinks. We're a very large state with over close to 40 million people, to start with a pilot in an area that already has a high degree of integrative care.
Do you think that the amendments, aside from the support and the organization of the chair may have input on this, will change the perspective of hospitals that may have been in that area but opposed previously, or do they like it more because it's...
We adopted these amendments this morning.
Okay, so not sure yet. All right. Thank you, Mr. Chair. Thank you, Ms. Eggman.
Okay.
Mr. Ridley-Thomas, Psychiatric Association. Perhaps I can add a little bit to what Ms. Eggman said. In looking at the concerns that were raised and the discussions with the chair, it became clear that there was doubt as to whether a registry would help some of the outlying rural areas, because you really couldn't transport people in time to be able to use a bed that might be open. When you look at regions like the 9 Bay Area counties and adding San Joaquin County, which is closely connected to that. Okay. What you end up with is a system that is already in close communication. For instance, on trauma care. They already use a registry on trauma care. Now, I'm sure these gentlemen know more than I as to why trauma care would be different than psychiatric beds, but nonetheless, they use a registry, they communicate this information, they have a robust system that allows for them to share information. Looking at that example, we believe that in the 9 Bay Area counties, they have a better chance of using this system, and for us to be able to glean from that whether, in fact, it can be successful statewide.
And this registry is an electronic registry?
Correct. It's a registry they already use. This will be just an added column. This is again, one agency or one organization that provides this is already doing business in the Bay Area counties and has already helped them set up the registry for all the other issues that they track.
It's a known and accepted technology. We believe something like that could be replicated quite easily. I'm sure they would have other views, but based on what our review of their studies of that system, we think that it easily is scaled for this.
And for psychiatrists believe that your experiences in other states are greatly enhanced by registries?
From what we've seen in other states, the fundamental problem, particularly in Virginia where a study was done, was that it was voluntary. A voluntary system results in a lack of utilization. A lack of utilization ensures failure. So in our view, we need to find out whether a mandatory system can overcome the problems identified in the state of Virginia.
And also in the state of Virginia, they have a different mental health system than we do. Ours, people with severe psychiatric conditions are in state hospitals, are sort of out of the loop, which is not the case in Virginia. So there was a lot more moving parts, and the system was not updated in the way that we imagine it should be updated.
Okay, I'm a little confused, and I think because you're doing a lot, so I'm going to support it in concept. Did I hear you say that different from Virginia, people who are suffering from severe mental issues are in state hospitals here, or vice versa?
Here we have a mental health. We have state hospitals.
You mean developmental centers, or do you mean state hospitals?
We have state psychiatric hospitals.
Oh, state psych hospitals, not those that are for the forensically mentally, those who are pleading not guilty by virtue of insanity. That's not what you're referring to, right? Okay, all right. Got it. All right, thank you. Thank you, Mr. Chair.
Thank you. First of all, I want to thank you for bringing this bill forward. It's a really challenging issue, obviously. There's absolutely no question there's a shortage of beds available for individuals experiencing a mental health crisis, and the current process of identify treatment options is untenable. As recently as yesterday, media reports have highlighted how families have to resort to phone books and call through facilities individually until they find an open bed. Yep. Almost half of our counties have no psychiatric beds at all, and this is unacceptable. We must do more, but we also need to make sure we do it right. The registry in this bill has some missing pieces, which I hope that as we go forward, we'll be able to do that. Who can enter the data into the registry? Who can search the registry for available beds? What kind of training do the people working with the registry have? Is this just physicians, or there's other people? And we also have heard similar issues and similar efforts in other states have resulted in lack of care because of false identification of an open bed and lack of uniform use of a registry, and that's one of the reasons that mandatory use of a registry is important, we believe, because if there's an uneven implementation, you're going to have additional problems, which we already have. So I want to thank the author for accepting the amendments. making this a pilot program. Encourage you to work with the stakeholders to make, as we go forward, to make this even better. And I probably should have let you close before I said that. But that being said, I will let you close.
Thank you. And yes, our intention is to continue to work on this. So, I mean, I think people have been covered all the points. And I will say, as I said in the beginning, and also as a researcher and a clinician, nobody is questioning that there aren't enough beds. We need more beds, but to not do anything while we wait for more beds is also it's untenable. So again, this is one step. It's a pilot. We think it's going to be effective. We won't know until we actually implement it. It certainly can't be worse than the system that we currently have in place, and I respectfully ask for your aye vote.
Great. Thank you very much. We'll bring it back to the committee for a motion. Is there a motion? Motion?
Second.
Second. I will ask for the roll to be called. This motion is due pass as amended to appropriations. Thank you.
Wood?
Aye.
Wood, aye. Mainshine? Bonilla? Burke? Campos? Campos, aye. Chu? DeBobne? Gomez? Hernandez? Lackey?
No.
Lackey, no. Nazarian? Olson? Patterson? Ridley Thomas? Ridley Thomas, aye. Rodriguez? Santiago? Steinor? Thurmond? Waldron?
So we have it's three. The vote is 3-1. We are we still have 7 short and a whole bunch of members short. So we'll keep that open, roll open for you.
And if we don't get the votes, I would ask for reconsideration.
Thank you. Thank you very much. Members of the committee can present. Ms. Waldron, would you like to present? No more bills have been pulled, so we just have members of the committee.